better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the untethered way, where better breathing meets better living. I'm Dr. Meggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise,
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started.
Hi, everybody. I'm Dr. Liz Turner, and we have Dr. Meggie Graham. This is No One Told Me, the Airway Health Connection podcast. And today we have a very, very special guest all the way from the future in Australia, Dr. David McIntosh. I was just saying that when we started this podcast, the first person I wanted to have on this was him, because I just feel so excited about all he's doing to help promote airway-focused care in the ENT space. I am going to introduce him as an Australian ENT surgeon with a special interest in airway health, sleep disordered breathing, and pediatric ENT care. Dr. McIntosh is known for his collaborative approach to airway medicine, working alongside dentists, orthodontists, and other healthcare providers to better understand how craniofacial development influences nasal airflow, sleep quality, and overall health. He's been a huge advocate for expanding the conversation around airway treatment to include both surgical and structural solutions, including tonsil and adenoid management, as well as orthodontic interventions such as palatal expansion. His work emphasizes early identification and interdisciplinary care to support optimal breathing and development throughout early childhood. So with that, let's get rolling. Thanks for joining us this morning for you.
It's an absolute pleasure. Thank you both for the opportunity.
And we were speaking before we started, but it is currently 6:30 in the morning, Brisbane time, correct?
That is correct.
So I just had another cup of coffee at 2:00 for no real reason, but it just felt right since it's morning for you. Not a big advocate for afternoon caffeine, but it's Saturday, so we're just doing it.
Okay. All right. Hey, look, you do what makes your heart sing, right?
Totally. Well, and if you want the honest truth, I actually messed up the time zones because we just had daylight savings. So I had this slated for 1:30 MST, 2:30 CST. Instead, it's 2:30. So I was like, I'm going to go make a cup of coffee.
Yeah.
Anyways, well, why don't we get started with just like a basic but big question? Why snoring in young children matters. Many parents are told snoring in toddlers is normal. They're going to grow out of it. From an ENT perspective, why do you think a 2-year-old snoring is actually a huge red flag? What does that tell us about their health?
Yeah, for sure. So there's actually a few dynamics in terms of just that question alone, but we'll start at the bottom and work our way up. So what is snoring? I mean, let's deal with this. So snoring is a noise that's made when you're asleep, and it's made due to predominantly one of two reasons. One, which is the big one, is because there is something blocking the breathing. So noisy breathing is bad as a general comment. So something is either blocking the breathing, or the other thing is there is something within the air channels that's moving around, much more than it should be. So that's what snoring is. Now, why is it a problem in children? The starting point with children is that their airway, size-wise, is, give or take a quarter of what you and I have got. So from that point of view, they don't have much room to play with. So when they start to snore, mostly in children, it's because that space is being encroached upon. And the reason it's a worry is it's like a warning sign. It's telling you the breathing is a problem. So any child or parent that's had a child, for example, with asthma, down in the lungs, where the airway starts to narrow in the lungs, they start to get that wheeze. Any parent that's had a child with croup, where they get that sort of raspy, rough sort of sounding breathing, which we call stridor. that airway is being encroached upon. And it's the same with snoring. Now, the problem with snoring is in that it ties into the airway starting to be obstructed, as a reference point, is that breathing is all about oxygen. And if you're not breathing properly, you're not oxygenating properly. And the problem is, and this, is a bit of a downer for adults to learn, but adults can kind of get away with bad breathing better than kids can. Kids don't get away with bad breathing simply because they are on a huge trajectory of growth and development relative to what us as adults have already been there and done. So these children, in particular, with their brains, have an enormous amount of brain activity at night. And the brain really needs three crucial ingredients. It needs sugar, it needs oxygen, and it needs sleep. And what a lot of people don't realize is if a child has a breathing problem that then mucks up their sleep, that child actually has two problems. They have a breathing problem and a sleep problem. And you've knocked out two of the supports for the brain. So if you were sitting on a little chair with three supports and you knocked out two of them, you're just going to fall over and fail. And that's why this is such a problem, because it's only minor degrees of oxygen deprivation in a child that is enough to be detrimental, whereas that same oxygen deprivation in an adult wouldn't be anywhere near as dramatic or deleterious.
Well, and I think one of the things that we'll often hear is that they sleep fine because they go to sleep and then they wake up in the morning, and I don't think that there's understanding of what's actually happening during the sleeping hours.
Yeah, it's very easy to confuse duration or quantity with quality. And as I often say, 4 good hours is better than 12 bad hours. Because at the end of the day, sleep is not only time based. There is a sequence of things where you go through what's called sleep stages, and that then brings you into a collective thing known as a sleep cycle. And you sort of start at A, and you take your journey through to B, C, and D, and then you go back to A and you do it all again, and then you do it again, and you do it again. And in adults, roughly speaking, we're getting about 5 or 6 sleep cycles a night. Children can be anywhere sort of 6 to 8 or beyond, depending on what age we're talking. But those stages are critical, and it's like building a house. If you want to build a house, well, you lay the foundations, and then you put up the walls, and then you put on the roof. And you've got to do it in that order. If you start with, putting the roof on the ground and put the foundation on top and then put the walls, you don't have anything that looks like a house. Even though you've got all the ingredients in terms of what you need quantity-wise, the quality of that assembly is not going to give you a structure that's going to be anywhere near useful. And that's where people get tripped over. I hear it all the time too. So, how's your child sleep? Oh, my child sleeps fine because they go to bed at 7 and they wake up at 7. And you go, okay, and what are they like in the morning? Oh my God, talk about, being tired and grumpy. And I go, well, they're not sleeping properly. That's not, from the parent's point of view, it's great. If the child goes down at 7 and wakes up at 7 and doesn't come in, 3 or 4 times through the night and interrupt them, hey, that parent's happy. As far as that parent's concerned, that child's sleeping great because the parent's sleeping great. They've gone from that transition where, as a baby, as we all know that, mums, unfortunately, the most amazing group of people out there because, well, you are, let's not take this for granted. The problem is we just don't remember because, we were so little, we don't remember it, but we know it all happened. None of us would be here if it hadn't been for that nurturing that comes through. Well, the majority of us would not be here if it's not for that nurturing that comes through. And part of that is you're up all hours of the night and your sleep gets wrecked. So the first window where your child sleeps through a night, that's the best night's sleep you ever got in a long time. So all of a sudden your child is sleeping great because you're sleeping great. Now, you don't know how your child is sleeping unless you're there watching over them, listening. And, this is often happens is, oh, my child sleeps great. My child sleeps great. We went on a family holiday. My child's sleep is terrible. I had no idea. They're
Mhm.
so noisy, and I think they stop breathing at times, and they're choking, and they're tossing and turning, and they're sweating, and they're restless, and they're tired in the morning. And I thought there was good sleep, but I'm not so sure now that maybe the quality's not there.
Liz,
I
how often do
think,
you have those patients come in and after like a spring break or a holiday and say like, we noticed this
oh,
for the first
all
time?
the time. I mean, I think that's one of my big questions too is I don't know what it's like in Australia, but in the United States, there's been an incredible increase in the diagnosis of ADHD and ASD. And of course, there are other factors at play. But would you agree that so many of the symptoms of sleep disordered breathing are also the symptoms of those other conditions? Like, are you seeing that in your clinical practice as well with these behavioral issues?
Oh, look, I mean, this is not news. If you, history is a beautiful teacher. The problem is that a lot of people don't know history. So if we do contemporary history, that research came out, initially the better paper was 20 years ago, where they had kids turning up to ENT clinics. A lot of this, we might go into the weeds or not. It's not so crucial, but a lot of this conversation has evolved and processed over time. So in 20 years ago, okay, so we talk about how it was done then. What would happen is children that was snoring would have a sleep study. And if that sleep study showed the child had obstructive sleep apnea, then they would get referred on to an ENT to have their tonsils and adenoids removed. So what they did in this research is they had a group of kids, about 120 children or thereabouts, that had gone through that process, and they were lining up to have their surgery. Now, before they did the surgery, they got in the pediatric development specialists, psychologists, psychiatrists, etc., and they did assessments of these children for ADHD. Okay, so just using the criteria for ADHD, and within that group, there was a huge rate of ADHD in terms of what met the criteria. And then what they did is they proceeded as planned. They did the surgery, and then they circled back 12 months later to revisit and reevaluate these children. And in that one study, half those children no longer tick the boxes to be called ADHD. Half of them. All right. So that was 20 years ago. Now, if we go back in time, and this is one of my favorite quotes, and I'll kind of get it right, ish, is actually from the 1800s. Okay, it's from 1889. A person called William Hill, and look, you're all going to have to take a little politically correct back step at the moment. You've got to remember this is the era on the time. Okay, so that paper that I'm going to reference is called "On the Causes of Backwardness and Stupidity in Children." That was the
Mm-hmm.
name of the paper. Now, good luck getting that paper title out now, but that was just at the time. And it's a brief thing. You can look it up. It's fully available. This beautiful thing called the internet lets you look it up. And what he talks about basically says, and this is it, the stupid, lazy child who sleeps with his mouth open, is tired at school, has trouble with concentration and focus, is well worthy of the solicitous attention of the school medical officer. Now, back in the day, schools had doctors. That's sort of how it worked. You had your doctor at the hospital. And they're saying, look, these children that are struggling at school. This is in the 1800s. These children that are struggling at school, snoring, mouth open, tired in the morning, struggling at school, go get them checked out. And, we're having this conversation now, effectively nearly 150 years later, trying to make people aware of this when, it should already be front and center. This
Right.
should just, the thing to me, as grateful as I am that you've both invited me, we should never even be having these conversations. Like this just should be the norm.
Right.
The fact that we need to re-educate the parents, re-educate the population, and then the knock-on effect that is re-educate the healthcare providers as well
It's
about
absolutely
this
maddening. Hmm.
is
Can I ask,
is 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 a problem.
can I ask a question? Why
Please.
why do you think that is? Because,
Mm.
Liz and I are up against that all the time and I wonder, is it because we're dentists or whatever? But the number of times that we receive pushback from our medical colleagues or even our dental colleagues that are like, there's no research, that's not true, you're fear mongering, that's just to me, to
Yeah,
us, it's black and white and it's so obvious. But why
yeah,
why the pushback when there's just so much time and
that's
research that
yeah.
shows it?
Yeah. So I think it basically, all in all honesty, now you got to realize I'm a surgeon. All right. Now, again, you can go look this up. If you look at when they profile narcissistic people, in terms of what sort of work they do, surgeons always top, near the list. Okay. All right. Okay. Now, some part of that is actually functional. We actually, to do what we do, we need to be a little bit authoritative. We need to be a little,
Absolutely.
we need to have self-confidence, but not overconfidence. So when you look at sort of narcissistic traits, what we do, as much as, it gets underplayed these days. I'm going off tangents, but you'll see if something goes wrong. Say someone has their appendix out, and the media will say, patient dies having routine appendicectomy. There is no such thing as a routine appendicectomy any more than there is anything such as a routine dental extraction, a routine tonsillectomy, a routine grommet. Like what, routine, there is no such thing as a routine.
It's all
Okay.
surgery. Hmm.
It is all surgery. It all comes with risk. It's like saying, plane crashed on a routine flight. There is nothing routine about that flight other than the fact that the exceptional training and skill that goes in to make that flight feel like it was routine and a non-event is what gets hidden by just how much skill and diligence and professionalism goes into this in the first place. And I think that's where people lose sight of it, and that's where it gets misunderstood. In terms of what we do in that context. So back to your question, why? Why am I going through this? Ego. That it's as simple as that. The reason that I am here now, quite honestly, is because I was wrong about things. And it was the dental community that pointed it out to me, and there's, thing called, social media. Back in the day, it actually used to be social. It ain't so social anymore, but it did, once upon a time, it actually did used to be quite social. And I was starting to hear things that I had never come across. And my initial reaction was, that's not true. That's nonsense. And the perfect example is with what we're talking about here is sleep disordered breathing. I lived in ENT world. The ENT world was you take out these kids' tonsils and adenoids. That's all you need to do. You fix these kids forever, and that's it. We're done. And then someone sort of said, no, actually, it only works 80% of time, and a good number of that 80% actually relapse a few years later. My initial reaction was, yeah, no, that's not true. We're amazing. We fix everybody for life. But I went and fact checked it. And it turns out they were right and I was wrong. Now I had a choice right there, right then. I had a choice, okay? Mentally, I could have held my ground, maintained my ego, and affirmed myself as being all knowing and all powerful and always right, and just gone on my merry way, fixing people forever perfectly. Or take a dose of medicine, realize that I don't know everything, realize that everything that I thought initially was, the be all and end all isn't the case, and go and learn why. And that's what I did. So the only reason, in all honesty, that I'm here now with the version of me that you have got is I checked my ego at the door, and I accepted the fact, unknowingly, that what I had been doing overall was right, but collectively was wrong because I wasn't looking at the everything else. And look, part of it is training. I am not dentally trained. If you want to put me in a room, me and a group of dentists, and you want to make me the dumbest person in the room, start talking dentistry. It won't take long before you realize I don't know squat about dentistry. And you know what? I don't need to. But at the same time, I do. Because the reason I do is because I need to know how your world interrelates with my world. because the overlap, once you see it, you can't unsee it. We talk about things, teeth. All right, how the teeth align, early dental caries, molar hypomineralization, bruxism, the gums, gingival disease, the jaw structures, your class 1, your class 2, your class 3, your constricted maxillas. All these things are not ENT domains, but it turns out they really are. And that was not taught to me. I did 6 years of medical school. I did another 10 years of surgical training on top of that. 16 years. And you know what I learned about teeth grinding in those 16 years? Zero.
Isn't that
Gum
funny though? Because
disease?
it's the same thing
Zero.
for us. We don't learn how to collaborate with the ENTs. And if we think about it, what we work on, the oral structures, the dentistry, is surrounded by the ears, the nose, and the throat. There's
The
nobody that should be communicating more than dentists and ENTs. And one of my favorite quotes from the literature is at 12-year follow-up post TNA, people are still symptomatic if we don't address the structure of the jaw, which happens to also be the structure of the nasal cavity. So
yeah,
why is there such a pushback when we have all the literature? And I agree with you. I think so much of it is to be the exceptional surgeons and medical providers that we are, we all have some degree of ego. And it's hard to play well in the sandbox if you don't necessarily see eye to eye. I think that's one thing that I've really always admired about you is you're willing to put this information out there and have hard conversations against internet trolls and social media when people
yeah,
are being social but not friendly.
yeah. Well, look, I mean, part of the problem is that all the social media platforms and formats, they are not conducive to conversations. There's no intonation. There's no, I was only being silly. It's not a conversation. Like if I say something, you can say, "Hang on a sec, can you just clarify that some more?" And we can sort of go off and back and forth. You don't sort of, it's so vulnerable to misunderstandings and misinterpretations that these days just escalate. So,
And everyone's showing up with like braced. Everyone's showing up ready to be attacked, that I think that they're not
yeah,
willing to show
yeah,
up to discuss.
yeah, yeah. And there's so many things that, what I worry about in a lot of these spaces is the almost sort of the religious context that things are being talked about. I don't work in the healthcare space. I don't work in a faith-based system where I'm based on belief. I work on what does the science show. What did I learn today? Oh, okay, I didn't know about that. All right, I just learned something else. Or, oh, that helps me understand something better. you know
Well,
um
and when you're looking at your patients individually, you can't just believe all one thing. Like, we
you
have to
can't.
look at the individual person. And I think
Yeah.
that's where, like, coming from you and hearing that tonsil and adenoid hypertrophy impacts breathing, sleep quality, and ultimately the health of the person, that's something
Mm.
we run into often. Our patient population many times is quite holistic. And I'll say
Mm.
it, I'm a crunchy mom, but I also have one foot in Western medicine because I'm not necessarily pro surgery, but I'm pro good breathing. And if
Mm.
surgery is a part of that, I want to emphasize how important that is to families. Like, where there's so much fear mongering in social media of surgery's bad, don't remove the tonsil and the adenoids, just do expansion. When really these things can often be a piece of the puzzle to get a person
Yeah.
healthy.
Yeah. And look, that's probably a good sort of headline. Just to actually, let's just put some numbers to this, just to sort of get some context of it. If we have 100 children presenting with what we call sleep disordered breathing, so let's pause on that one. What is sleep disordered breathing? Sleep disordered breathing is a spectrum. Now, I talked about 20 years ago. Historically, the paradigm was about obstructive sleep apnea. Now, it turns out, so that paper was 2006. In 2012, there was a paper that basically shot all of this out of the water. And to me, of all the papers, that should have been the one that everybody just stopped on and just pivoted on. And that was by a researcher called Karen Bonnock. And that was a paper where they got 12,000 children.
1,000. Yeah.
Okay, 12,000 children. It was done in the United Kingdom. And they watched these 12,000 children for the first 7 years of their life. And they had the radar on for children that develop sleep disordered breathing. So sleep disordered breathing is a spectrum. It can be mouth breathing, it can be snoring, it can be struggling really hard to breathe, and then it can be the apneas. And what they found, which is very, very standard now, okay, when we look at anything else, they found 20% of children through the first 7 years of their life develop sleep disordered breathing. Now, the thing they did in this study, which in my mind means you can never do this again, they did nothing. All right, they did nothing. Okay, and they watched to see what would happen in terms of the kids that did or didn't get sleep disordered breathing. So out of those 12,000 give or take kids, 20% with sleep disordered breathing, 80% without. Okay, what happened? Well, they noticed, when it started, and so forth, and when and for some kids it also finished. It came and went. Okay, so this is going to address they outgrow it paradigm when I finished round this off. They also, and they defined it basically they got the parents to watch over the child. Does the kid snore, mouth breathe, stop breathing at night? And when they crunched all the numbers and all the data set, which you can do when you've got 12,000 kids, you've got all these data points, what they found is that if the child had mouth breathing, snoring, stopping breathing at night for 6 months, whether it went or not, okay, whether it persisted or not, if they had it for 6 months, that child had adverse outcomes as a group, compared to the kids that never got airway problems. Okay, and that turned up in their learning and their behavior and their concentration and their emotions and their peer-to-peer relationships. So the only thing that went wrong in the developmental stages of these children was they got sleep disordered breathing. They checked for everything else. They looked at all the things that can sort of give you a false signal. They checked all of that through, and that's what they sifted out. And so that what they found is the younger that it started, the worse the long-term outcomes. The longer it hung around for, the worse the long-term outcomes. And to highlight again, it only took 6 months for those children to, down the track, have signs that it had mucked up their development. And what people need to just pause on is, and when you look at it, when you think about concentration, behavior, emotions, learning, the common factor there is brain function. All of those things are brain function. These children's brains down the track are not working properly. So, to my mind, that paper should have changed everything there and then as to how we approach this. And if you read that paper, it actually says, in the conclusion, words to the effect of, this research indicates that, children with upper airway obstruction need to be identified and treated early, and also much younger than what we thought, because the youngest ones are the ones that cop it the most. So I'm sorry that was a tangent, but let me wheel back to where I was. All right, so we've got 100 children now with sleep disordered breathing, whether it's snoring or mouth breathing, whatever. The reality is, if we look at those children as a averaging population, 80 of them need surgery. If you are genuinely going to address what is going on, 80 out of 100 need surgery. That's your starting point. In terms of the contributing pathologies. So what are the contributing pathologies? Well, the number one is tonsils and adenoids. It is the number one by far. There is something that is rapidly racing up the charts, though, especially here in Australia. And from what I'm observing on the research, it's happening across the world, and that's nasal allergies. Nasal allergies are showing up in my clinic far more than they ever used to. And they're showing up with far greater severity. They're showing up at much younger ages than they ever used to. And they are ending up needing surgery far more often than they ever needed to. I'm old enough to have been in this game to have seen this happen. I know what I was doing 15, 20 years ago for these children with allergies and stuff. And when I was doing it and so forth, the world has changed around me.
Do you feel
Now,
like our environment is contributing to that? That's one of the things we speak
so,
to often is just
so
the way
yeah,
that our air is.
yeah. So the reality is there's lots of things that have happened at once. Okay. And when we sort of sit back and look at it objectively, there are a few things that certainly stand out that seem relevant. Now, of those, there's always been this thing called the hygiene hypothesis. It's also known as the farm hypothesis. And the suggestion is that we've made our environment so clean and so sterile. Our children don't climb trees and they don't make mud pies, and and they don't get dirty anymore. And we're getting Swiffer around the house, and removing every microorganism, because germs. We've become so over the top in insulating ourselves around this, that's opened the door for things to show up as allergies, because we're just not getting the normal challenges that we used to have. So our immune systems are going sideways. Now that seems to have some validity, but there's two things which are looking more relevant. One is definitely showing up. The other one, there's only small signals so far. So the one that's definitely showing up is early exposure to antibiotics. And the theory and the rationale there is that it's changing the gut microbiome, and we've got a better understanding about gut, brain, gut, immune system axis. Now, this is where we just got to back off for a moment and just not throw the baby out with the bathwater. Okay. Antibiotics are one of probably two major health changing things. In terms of what changed things, the two things in my mind are antibiotics and anesthetic. Okay, anesthetic has facilitated a whole range of treatments that we all take for granted now. Antibiotics have saved an enormous amount of us from dying. If you look at life expectancy, now you two are both quite young. I'm old and crunchy. Your life expectancy, if you and you can look this all up, in about 200 years ago, it was 40. 40. That was your life expectancy. And the things that were taking you out were accidents and infections. They were the two things that were taking you out. Accidents, because a lot of the work was manual and so forth, and people would have work accidents, and that's just these. But a big one was infection. And for women, it was childbirth. Childbirth back then was a major cause of death in women. So again, there's no such thing as a routine pregnancy. It's good when it goes routine, but there's no such thing as a routine. So from that point of view, antibiotics, are absolute crucial part of the healthcare system. But what it just emphasizes is we need to use them judiciously. Now, if this means that, your child has a serious life-threatening infection at 6 months of age, don't even think twice about using antibiotics. Okay. And if, down the track they get allergies and you go, oh, that's because of those antibiotics I gave them at 6 months of age. No, maybe, but they're still there with you. Like everybody wants perfect, but this is all levers and pulleys. You pull on one thing and that adjusts something somewhere else. So so early exposure to antibiotics seem to be one of the players in the game. The other one that is starting to signal a bit is this microplastic thing that we're getting told about. That horse is so far out the gate. There's no reining that one in anytime soon. But that is a concern. Is that this microplastics is already so entrenched. It's changing the way that our immune systems work. It's changing our endocrinology, and there's all these sort of elements there. And again, we just have to accept we know about these things. We can be mindful about these things, but we can't be paranoid about these things, because being paranoid is actually, the worry of it actually then, can feed into other problems as well. So I think this is just about understanding, why are allergies, going through what they're going through. Well, there's those things, are the big ones.
For sure. Well, and we say that a lot. Control the controllables. There are things that we
Exactly.
can control. And if you have a child with recurrent ear infections, maybe throwing antibiotics at it over and over again is not the solution. Maybe it is looking at, are the adenoids mucked up and causing fluid retention and causing infection? Is the
Yeah.
tongue not engaging with the roof of the mouth to pull on the muscles that control the eustachian tubes? Like, if we look at the structural impact of why we need the antibiotics, that's where the dentist and the ENTs can work better together. The problem is in
Yeah.
our space, we're generally not assessing children without teeth. And I feel strongly that in our profession, we should be looking more critically at function in individuals without dentition, but we're not trained to do so. So, I mean, that's where this kind of controversial topic of the tongue tie comes in. We feel strongly that there are many individuals who have restricted mobility that impairs their structural ability for muscular function as well as growth and development. And I know in the ENT space, that can also be a bit controversial. We think that everybody should have a functional evaluation and intervention well before treatment, but it can be quite confusing for families. So, what are your thoughts at this time on tongue ties, lip ties? And again, we're totally open to dialogue.
Yeah, yeah, sure. So I sit in a place of confusion. I've been doing tongue ties for over 20 years. So I look at this with some sort of confusion, it's like what, like we just got to sort of sit back and just go, if when I look at tongue ties, I basically sort of say, look, the most prominent time they're going to show up if it's a problem is with breastfeeding. Number one. All right. Now, the reality is that the most common cause of breastfeeding problems is not a tongue tie. The most common cause of a breastfeeding problem is that you're a first-time mum who hasn't got adequate support, guidance, and help, and you're doing the best you can, but you don't really know how to do it because you
And
just
when you
don't have
ask
that
your
support.
Yeah, and you ask your pediatrician and they don't have any training in feeding. And at least
No.
in our country, in our system, if they don't have ability to breastfeed, it's quick to just say, oh, well, you can use a bottle and formula. And to your point on life expectancy, morbidity and mortality in infants who couldn't feed 100 years ago was extremely high. And now
Yeah.
we have all these amazing interventions to help babies live and thrive, including like
Yeah.
different shaped bottles, formula,
Yeah.
different
Yeah.
pacifiers. Like we didn't have
Yeah.
that back then.
Yeah.
So,
Yeah. Yeah. And look, I think again, because I'm just mindful of you, because we mentioned, none of this is to be disparaging about choice. If people want to choose breastfeeding over bottle, like we have the privilege of choice, and you're fully entitled to choice. But in the context of where breastfeeding, definitely should be encouraged for the multitude of reasons, accepting that it doesn't always work. The number one reason when you look at it is that it's a first time mum. That's the number one reason that there's problems. What's the number two reason? It's a tongue tie. It's the number two. But the problem is, what I see sometimes is that, the struggle is real and the solution is a tongue tie release. We had this thing, I don't know what was going on over there, but we had this thing 10 years ago. Mums were pre-booking their tongue tie release for day one of birth. Like they were actually booked into clinics to have a tongue tie release basically as soon as the baby is born.
oh, that's so challenging. And how many of them
All right.
were failures because we didn't
Well,
address
no,
the
well,
function?
well,
Yeah.
well, 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 none of them were failures. They weren't even born.
Yeah.
These clinics,
Fair.
these clinics were basically preying upon, the once bitten, twice shy scenario where the mum had been through, a quite genuinely horrendous experience. And, that got attributed to a tongue tie. She never wants to go through that again. So, her response, which makes perfect sense, is to go, oh, well, I'll just want to get my next one fixed before I have these problems.
We say
So
so often that our
right,
first children are our first teachers. Like to your point about first time moms,
100%.
we learn so much from our first kids. Our general approach towards getting people treated for tongue ties is you should pre-book with your lactation consultant to give you guidance before your baby's even born. Because
Yeah,
though the
exactly.
tongue tie is a thing and it's a big thing, and all that's the soapbox I will die on, the function is the part that has to improve for it to be effective. And that includes pulling on the eustachian tubes and elevating to grow the jaw. And
Yeah, exactly.
it's
Well,
hard.
we'll even say that into, function of a child or an adult, that if there's a restriction in oral tissues that is preventing optimal muscle function and it's causing compensation, our job as structuralists or surgeons that release with functional frenuloplasty is only there as an adjunct to the therapy, only there as an adjunct to
Yeah,
getting the function correctly. So you have
yeah,
to start with the therapy first and the functional approach, and
yeah,
then only then does that even
yeah, yeah. I
offer
mean,
support or help.
we're facilitators. So, and this is again, this is where the tongue tie problem has evolved, because of social media, because social media, at the end of the day, is photos. Oh,
Mhm.
do you think this is a tongue tie? Do you think this is a tongue tie? Do you think this is a tongue tie?
Can't
That's an
diagnose with the
appearance.
photo.
That's an appearance-based assessment, and this is the challenge in this space. Is if we're going to be realistic and honest, to this day, as we sit here right now, we do not have a single universally accepted method of assessment for a tongue tie in the context of breastfeeding. We still don't have one. There is not a single one out there. There's multitudes out there, and they've all got their pluses or minuses, and what people do or don't subscribe to. But ultimately, the problem is that a lot of the things that are on the social media space, it's all just photos. It's all just that it creates the impression that it's about appearance, when in actual fact it's everything, as you've said, about function. And my approach is very simple. If that mother is feeding perfectly, if that child is thriving brilliantly, quite honestly, under that situation, at that moment in time, I don't care what the tongue looks like. I really don't, because all I would be doing is basically making it look better. That we have a name for that. It's called cosmetic surgery. There is no justification for cosmetic surgery, in the situation where both the mum and the baby are doing absolutely everything spot on that we would expect it. Even if it looks like it's the tongue that just doesn't even move, I don't care, because I would be doing it to make it look better. And that is not the reason that you want to be intervening, because the last thing you want is to create a situation where you interrupt something that is going so well and then end up with an oral aversion because you created pain and you disrupted the feeding for a bit. So I'm very much about function as well. And I will see these photos where you look at it, I see these tongues and you look at them and go, oh my God, how does that tongue even move? And you go, the kids turning up when they're 4, and you go to mum, any breastfeeding problems? They go, no, they're great. I breastfed them until 2, no problems at all. You go, okay, great, awesome. There might be some things that are starting to show up now with speech or with jaw, but okay, we'll deal with that now because it's shown up now. So I don't rely on appearance. In that context, I'm looking for functional issues and consequences of the same.
So
Um,
that's one thing we run into in the US a lot is instead of looking at it and saying, hey, I see that there could be some tension here. It's not causing an issue now, but you
mm,
should be aware maybe in the future to look out for
yeah,
X, Y, and Z. In our
absolutely.
country, it's very quick for providers to say, tongue ties aren't a thing. This won't cause you any problems. So they don't leave the door open for the
Mm,
parents to continue to explore. So what
yeah,
we run into often is families that are quite upset that they were so dismissed and not really given the guidance to ask questions in the future if there are issues. And that just kind of goes back to the ego thing. So, I mean, I really appreciate your approach of function first. That's the most important thing. But
Yeah.
if X, Y, and Z show up later, it's okay to ask questions of
Yeah.
providers. We
Yeah.
just don't
And
have that.
yeah, and look, what I would also suggest is that it's possible for two scenarios to coexist. It's possible for under treatment and over treatment to
Correct.
coexist.
Mm-hmm.
Okay. So what you're talking about there is, at the time it might have been appropriate, but yeah, I agree. They should have been sort of flagged for the future. Just say, hey, look, just keep an eye out for this. It's the same. In my domain, my grief is the premature babies. By virtue of being premature, that baby is at a much higher risk of sleep disordered breathing later on for a whole range of complicated reasons that we don't need to get into. And I still haven't come across a single parent that was told that as part of their briefing of having a premature child. Not one.
Mm-hmm.
But we know. It'd be a
Yeah.
simple thing just to tack on and just say, hey, look, by the way, your child as is an amazing miracle of survival, but this is obviously not how life was supposed to start. And one of the things you want to keep an eye out for is snoring or mouth breathing. And if you start to notice that, get yourself an ENT, as quick as possible, because things are starting to go sideways, and they're going to go a lot more sideways, a lot more quicker in your child than someone else. But yeah, it's possible things to coexist. It's quite possible, like I was talking about before, having tongue ties literally booked in for surgery, surgery day one of birth, like C-section, might be planned. So you knew what the date was going to be, and you've got your tongue tie release planned the next day. That is over treatment, so overdoing it in that scenario is very possible. Just like the mum that struggles through, all sorts of misery, and pays a terrible price at all. And it's not a bonding experience at all. It's just a awful moment of pain and trauma because there was under treatment. So it's quite possible for the two to coexist, and this is what happens when you look at it from the other side of you. The very the pro tongue tie can be also very much elements like everything of there that is way over the top. And then the way over the top element meets the there's nothing wrong with you element, and that's where the clashes then show up. Whereas in the reality, I would like to think most of us live in the middle. Most of us know that it's a thing. Most of us know that improvements can come about by addressing it, and most of us know that you don't have to do it all the time, just because of how it looks. That's I just I like to bring a balanced approach to everything that we do, and it's no different to when I swap that around to tonsils.
Mm-hmm.
You can see, I've seen them, the most enormous tonsils you could ever comprehend, and that kid's fine. Their breathing is fine, their sleep is fine, their swallowing is fine, like everything that you would expect to be mucked up. There's not a single sign of it. So again, I don't take those enormous tonsils out, even though I look at them and taking them out would make me feel better. It's a cosmetic operation. I don't do cosmetic surgery in children.
Well, we actually had a conversation with some dentists recently. We're talking to them and teaching them our approach to things. And one of the questions is, what do you do first? What's the order that you do? Do you do tonsils and adenoids, and then you do expansion, and then you do a tongue tie release? And it's like, well, there's no recipe. You have to know how to diagnose, and you have to know how to discern. There's not a path that's going to fit every patient. You have to have those clinical skills. And if you don't have that, you shouldn't be providing.
And even with the age of the child matters. Can you speak a little bit to, because this is something we run into a lot. We assess many children that are 2 to 3 years old, and the families come in and they say, I want their tongue tie released. And I say, well, it's not the tongue tie now, it's the adenoids. And I'm concerned that the adenoids are going to continue to enlarge as the immune system enlarges. And that's something that's not commonly explained to parents. Can you speak a little bit to how the immune system is developing? And you
Yeah, for
mentioned
sure.
growing out of it because they do kind of drop back over time, but there is a period where they're actually enlarging, and
Mm.
families aren't aware of that.
Yeah. Well, what I might do, I'll just circle back to something. You said there's no recipe or guidance. So let me maybe just bring something to the table just to sort of, So by the time these children turn up, um, 2/3 of them, okay, 2/3 of them. So I talked about, the 100 kids. So, 80 need surgery. Well, blended amongst that, some within that 80, some within that 20, have orthodontic problems as well. Okay. Um, and it's not it's not ENT or orthodontics. And by
Right.
orthodontics, I mean jaw structure. Okay. Two
Orthopedics, yeah.
thirds of the time, 2/3 of the time,
Mhm.
it's ENT and orthodontics.
Correct.
So David lives in the world of lots of analogies. Okay.
I love it. I
So
love
we
it.
have a child that has fallen in the water and is drowning. Okay. Now we have a few things that we can do. One thing we can do is jump in and save the child and pull them out. The other thing we can do is teach them how to swim. Now, if that child is drowning, no amount of effort to teach them how to swim makes sense there at the moment. It's the right thing to do at the wrong time. Okay. You've got to save them. So if a child in that 2/3 is turning up with ENT and orthodontic problems, step one, you need a quick fix. So the short answer to your question is they actually need the surgery first.
And the literature
Okay.
supports that. It's the quickest way to get a child breathing better.
That is your lifeguard at the pool jumping in, pulling your kid out. Okay. All right. That's the reality of this. Okay. And then what we need to do is go, right, we probably need to teach your child how to swim so that we've got things sorted for the rest of it. And that's where the myofunctional therapy, that's where the jaw expansion comes into it. And again, this is just me learning from others. And I'm talking now about 10, 15 years ago. So 10, 15 years ago, I'm emerging and evolving and learning into this space as well. I'm working with dentists that have been doing jaw expansion longer than I'd been an ENT. All right, they got runs on the boards with expansion that far outweigh what this new kid on the block's done. Okay, and they're airway minded and airway aware. They've got CBCT scans, and they can see these kids are blocked. But at that time they could never get an ENT to listen to them, so they just said, "Well, I'm just going to expand them." And then they started sort of bouncing them through me, and I would address the airway problems because that's what I worked out I needed to do. And what those people with enormous amount of experience, okay, started to observe. This is what they've told me. I've got no reason to doubt it. And you'll see why when I get to the end point. They started to notice that the expansion was so much easier
Of course.
and it was so more stable because the
Correct.
ENT stuff was off the table
Mm-hmm.
to the point that they refused to even do expansion if the parents would not accept the ENT as part of the plan because they had seen such a different version of outcomes with initially without and then with ENT interventions. They did not want to own the failures. They did not want to own the struggles. They literally turned thousands of dollars of income away because they saw such a difference. Now, I can't speak to any higher level of credibility and integrity than what those people demonstrated in doing that. Because it's very quick and easy just to take someone's money and do something and then it doesn't work and say, oh, well, it didn't work because your child's still mouth breathing. And, well, I guess maybe we'll get don't set these things up to fail. Facilitate the success. So
I know that I know you like tangents. I want to ask this question because we get asked this a lot. And perhaps it's different regionally, is we have a harder time, and luckily where I am, I've got some great team members, interdisciplinary team members. We've got a lot of providers and parents saying, I can't find an ENT that will take out tonsils and adenoids unless I fly to Brisbane. Like I don't know what to do with those. I don't know what to do. My kid obviously has an
You just
issue,
fly.
but I keep being told, what was that?
You just fly to Brisbane.
Just
What
fly
am
to
I missing?
Brisbane.
Yeah,
I
Yeah,
mean,
what am I
should be that
missing?
easy.
truly in those
No,
situations, do you think in those
yeah,
situations where it's not parent directed, but
yeah,
there's no resources or access to care at that point, is it better to do something?
yeah. Hey, fun fact: I saw someone from the US yesterday. Um, but look, that's not the solution that needs to be on the table. Part of my problem in addressing what you're bringing up is part of this is a symptom of healthcare systems. And your healthcare system and my healthcare system and Canada's and the United Kingdom and so on, they are all so different. And that in itself can actually mold how things are done. And in your country in particular, it is the insurance companies that are driving the bus far more than the clinicians are. And because in your country it is so expensive, so expensive, it's changed since we had COVID. But if we go pre-COVID, we sat down and did the math. It was literally cheaper, honestly, that back then to get on a plane, fly to Australia, pay to have your surgery, pay for your hotel for 2 weeks, and fly home than it was to pay to have your surgery next door at the hospital in the US. That's
Crazy.
how expensive your healthcare has become.
Well, and some of the guidelines for us, you have to try Flonase for
Yep.
6 months, and
Which
many
doesn't
of
work,
them
by the way.
require a sleep study, which
Which
we have a
doesn't tell you
six
who
to
needs
nine
fixing.
month backlog.
Yep.
And the thing that makes me mad, and one of the things that I provide patients all the time, in the ENT guidelines from the American Academy of Otolaryngology, is that the consideration for adenotonsillectomy should include hypertrophy of the tissues causing dental malocclusion or adversely
Yep.
affecting oral facial growth. But it's
Yep.
like they don't read that little byline. And the
Well,
insurance companies also
again,
don't care, even though it's in the
well,
guidelines.
the problem again becomes the insurance company, okay? Because I dread even when you got insurance, like your copay alone can be thousands of
$7,000.
dollars.
Yeah.
Yeah,
Mm-hmm.
Your copay alone can be almost well, you help me. What would a copay be from your experience for having tonsils and adenoids out? Assuming you've got insurance, what sort of
And
copays you have?
It's so varied.
an
Yeah.
individual is normally $3,500 to $6,000.
Okay.
A
So
family
that's
plan is around $7,000.
all
Like
right.
that's a
So that
huge
so
chunk
all
of
right.
money.
All right. So that's US dollars, right? All
Mm-hmm.
right. So let me just for a moment just indulge me because this is I'm going to use your $3,500. That's 5,000 Australian dollars. Okay. 5,000 Australian dollars with zero insurance will pay for your surgery with a private specialist in a private hospital with a private anaesthetist.
Insane.
Okay. All right. So
Yeah.
your copay will cover the whole bill in Australia.
Crazy. We
Okay.
also hear that the ENT reimbursement for tonsil and adenoidectomy is far, far less than something
Hundreds
like
of
a
dollars.
septoplasty. Yeah,
Yeah.
it's
Which
very
again
minimal.
enters into the dynamics of it all.
Mm-hmm.
These things become the problem because again, um, at the end of the day, insurance companies have their prime interest being themselves. At the end of the day, that's just a reality. Okay, and they create all these barriers to access. Now, it unless I'm mistaken, you can elect to go and get your surgery done out of network and accept that you just got to pay for it. But the prohibitive costs involved with the same, I mean, it's quite honestly, from what you're telling me, if you're looking at $3,500 US is your copay, If you don't have insurance, or you're looking at going out of network to find someone that can help you, seriously start looking at Australia, or whatever, because seriously, those numbers are just ridiculous. You know, it would cost you, well, God knows what it would cost you if you don't have insurance. What do you have any insights? Like, what is let's go into the weeds here. What's an uninsured person going out of network? What are they looking at? Is it like 15, 20,000 US?
It's got it, because even to pay for the surgical facility alone.
Mm.
And I mean, that's where it gets really tricky, is because not only are patients being denied care, but then the dentists and orthodontists are often being put in a spot where if the families are denied care, they end up in our offices as an alternative when it should be an adjunct to the care from the ENTs.
Yeah.
And so it's become quite difficult to not, we don't want to overpromise to families, but to highlight, like Dr. Audrey Yoon and Dr. Rebecca Bacow's paper, there can be reduction in size of tonsil and adenoids. Nowhere in that paper does it say that it's an alternative to surgery. It says that it can be used as a tool to go along with tonsil and adenoid surgery where necessary, and potentially could be used to avoid if they're not so large. So it's a very healthcare driven and societal problem as well.
Yeah. Yeah, I've spoken to Audrey. I've heard Audrey talk about that paper. I think of all the papers, that paper has given her the most number of headaches. Good intentions with bad outcomes. Because you're absolutely right. There's nothing in that paper that says that these children didn't need surgery. Nowhere does it say that.
In fact, it was just CBCT observation. Yeah, it wasn't even like intended to. It was, let's look at what we have in our CTs.
There's nothing about that. The second thing is there's no control group, so you don't allow for that. It's retrospective. There's no clarification as to how those cases were chosen. And then Audrey said that she's repeating the study and doing it prospectively, and she's not getting anywhere near the same results. They're nowhere near as good. So bear that in mind. And again, just go back to that study of Karen Bonnock. But also, because within that cohort, children, in inverted commas, outgrew their obstruction, but they grew into brain developmental problems. So, if your outcome measure is tonsils and adenoids getting smaller, and that's the only thing you look at, you're missing the child that's attached to. And, it doesn't really matter. We've seen this in probably a better structured study was what's called the CHAT study. That was in the US. That was 10,000 kids. Half got surgery, half didn't, and they checked the kids 6 months later. Now, that basically broke up into then 3 groups. You had group 1 was the kids that had surgery. Group 2A was the kids that didn't have surgery and, in inverted commas, got better based on a sleep study. And group 2B was kids that didn't have surgery and still had problems. And when you looked at those 3 groups, the group that had the best overall outcomes are the ones that got surgery. The ones that had the worst outcome were the kids that didn't have surgery and still had an abnormal sleep study. And then the ones, that sat in the middle of those were the kids that had a normal sleep study but didn't have surgery. But everyone in group 2, the no surgery group, had a bad outcome. It's just that if you had ongoing airway problems, you had a worse outcome. So you had either a bad outcome or a terrible outcome. You did not have a good outcome if you didn't have surgery. The group that had got a good outcome are the ones that had surgery. So this is the whole thing about this airway getting better, airway outgrowing, and this is what you were talking about too. If we circle back, and we're good at tangents, and I'm good at bringing them back again, hopefully, because you talked about, my child's got big adenoids at the age of 2. What should we do? All right. So you mentioned the use of nasal steroid sprays. Okay. We've all got different brand names out there, but what you mentioned was a nasal steroid spray. That came out of a research paper that 2 years later was found to be methodologically flawed. I remember when that paper came out, I started using these steroid sprays and it didn't work. I was just like, I will do the spray and we'll see you in 3 months, because this research has come out, and they came back and it didn't work. Every now and then it worked, okay? But that was so few and far between. I just stopped bothering. And then the paper came out that actually then validated it. My guess is, this is pure speculation, is that, a good number of us as ENTs had seen that first paper. Nasal sprays fix adenoids. All right, let's go. Didn't work. Didn't work. And somebody somewhere sort of must have got a signal that, hey, all these ENTs are starting to notice that this isn't working. This research is not holding up into clinical practice. Let's go back and look at that research. And the research was flawed. The things that they said that they found, they didn't actually find. The methodology, the process was all wrong. So the problem is, unless you've read that second paper, which most people haven't, came out 2 years after the initial paper, you just keep doing the steroid sprays, even though it doesn't work. So there's your problem. You mentioned sleep studies, okay? Sleep studies were designed as a research tool initially to measure breathing and sleep. The thing called the AHI, which stands for Apnea Hypopnea Index. So just to explain this for people, because this might be new territory for many. Apnea means that you stop breathing. Hypopnea means that you don't stop breathing, but you're kind of choking. And we can measure those things on a sleep study, and we count how many of them you do, and we divide that by the number of hours you're asleep, and we work out how many episodes of breathing problems did you have per hour. And that's called the AHI. Yeah, the AHI was invented, again, as a research tool. It was like, we want a way of sort of measuring this and standardizing it and enable us to do comparisons. That's all it was invented for. And that went into the publications and so forth. Now, the problem is, and again, thank you, America, is your insurance companies started adopting that as their paradigm.
The standard, right.
Of how things will be assessed in terms of whether insurance kicks in or not. And that overflowed into pediatrics, even though, the pediatric measurements don't mean anything like they do. We use adult stuff in kids, which is highly inappropriate. It'd be the same as using an adult dose of a medication in a child. You might use the same sort of medication, but you have to adjust it to cater for the child. We don't do that with the sleep studies. And they literally just used initially the same numbers and everything. So we talk about in adults that now, in this current era, of an AHI of 5, and in children an AHI of 1. I'm just curious, do either of you know how those numbers were derived?
Tell us.
They were made up.
I love that. And what we tell families often is, whether your child has an AHI of 1 or an AHI of 20, the cognitive impacts on the brain are exactly the same. The severity doesn't matter. The fact that it's there matters.
There's actually no relationship. And then the other thing I want to highlight too, so let's just work on a very simple explanation, all right? So this sleep study can measure the blockages in the breathing. If your breathing stops or reduces, it's measuring, that's a reflection on the blockage. Now, let's just think about this for a very simple moment in time. The blockage is at the nasal level. So the adenoids sit at the back of the nose. Let's imagine they've got, your child right now has got the world's biggest adenoids ever to be found, and they're mouth breathing. Now, because they're mouth breathing, they're not blocked when you measure it. There's zero blockages because they're breathing around the obstructions. When you measure their breathing at night and you're measuring their apneas and their hypopneas, it's zero. And you go, oh, they have no obstruction. Mm-hmm. They do, but it's not being measured. So the problem is that a normal sleep study does not mean normal breathing. And right. I honestly, I've been doing this for 20 odd years. I'm getting almost to cranky old man stage, where I'm going to start, telling, these young kids, to turn down the music and everything else. That I would have done less than 20 sleep studies in my 20 plus pediatric ENT career. Less than 20. And that was because these kids were complicated and weren't making sense to me. I don't need overthinking. I don't need a tool that measures something imprecisely when I can see that this child is blocked. The history and examination, they align so easily and so well and so comprehensively that spending, and in your country, I dread to think, again, what your copay on a sleep study is, there's probably a few thousand there as well.
Thousands. Mm-hmm.
Yeah, that's insanity. I was doing the math before, just in the background. You could literally fly to Australia, a parent and a child, return ticket with accommodation and surgery, and you probably that'd be 10 grand US, which I know is not, which is a lot of money. Don't get me wrong, but what you're talking about, especially if people are having to go out of network and they're looking at $50,000 to $20,000. I'm thinking that Tourism Australia, you're going to start seeing some ads, for medical tourism, because seriously, those numbers are just prohibitive. But it also then, like you said before, it feeds into the surgeons. The insurance company has done everything it can between a medication that doesn't work, an investigation tool that's unreliable, and then a reimbursement rate that is somewhat, unfortunately, as a disincentive for someone to even be interested, that collectively actually delivers the result that the insurance company wants, which is people are not using it.
Correct.
Mm-hmm. I had a patient the other day, a 5-year-old, her tonsils were touching. She was extremely symptomatic. She'd never slept more than 3 hours at a time. The insurance company denied her tonsils and adenoids as a pre-existing condition. They said it was pre-existing, so they denied it. So both myself and the ENT she worked with wrote medical necessity letters. But for them to just straight deny a child the care as a pre-existing condition, it was like, pre-existing when? Was she born with it? Where did it come from if it was pre-existing? It's maddening. Well, Dr. McIntosh, this has been an absolute pleasure. I just have one closing question for you. If you could change one thing about how pediatric airway issues are approached today, what would you do? Like, give you control over the insurance industry and over the way that our education is. How would you love to see the future of your profession and ours progressing?
Look, the simple principle in healthcare: when's the best time to fix a problem? When you find it. It's the best time to start fixing it. And then again, just if you circle back, like, these insurance companies down the track could be saving themselves billions of dollars on what they are then down the track having to fork out to pay for the blood pressure and the diabetes and all the other things that go wrong because these kids weren't fixed. They get the adult version of airway obstruction and all the consequences of the same. They should almost, offer this surgery for free, because the payoff down the track to the insurance company, if you were to get an actuary to actually do the math, they'd be like, guys, we got to get all these tonsils out yesterday. Drop the barriers, get these kids in and get them fixed, because we're going to be miles ahead of health and wellness curves by getting these kids healthy at a much younger age.
That's fantastic. Well, truly, thank you for being such a thought leader in the industry and for being okay with changing when you saw that what you knew wasn't correct. And I think that's where Meggie and I both come from, is we've learned a lot from our failures. I was taught in residency that growing is stressful, grinding is normal in children. And I think of how many kids I let slip through the cracks because of something that I learned in my own educational postgraduate institution. So just because we learn something in school doesn't mean it's okay to just not evolve. So again, 100%. Thank you so much. And for anybody listening, if you have questions for Dr. McIntosh, we're more than happy to do a part 2, and maybe we'll just fly to Australia for it and go for coffee.
I think it should be live. I think it should be in person in the future. Yep.
Yeah. Whether it's Denver, Milwaukee, or Brisbane, we're there.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
please share it with someone who would benefit from hearing this. And don't forget to subscribe.
Want to learn more about Airway Health or connect with our team?
Please visit our website, untethererairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.